Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and we are going to continue on our month here talking about advanced directives and healthcare decisions. And today I've got Dr. Shana Semmens here with me. She is the medical director for our TMC Palliative Care team for the hospital, and she will be speaking about navigating comfort care from palliative to hospice. How are you today, Dr. Semmens?
I'm very well. Thank you so much for having me again. It's a pleasure to be here.
So I want to just share with everybody a little bit more about you before you get started. So let me just share a little bit about what you do. So Dr. Semmens is the TMC's Palliative Care Medical Director. She and her team provide a holistic approach to maximize quality of life for a patient and is designed to relieve the symptoms caused by serious or chronic illnesses. She received her medical degree from the University of Arizona College of Medicine, where she also completed a residency in family medicine. She later went on to complete a fellowship at the Medical University of South Carolina, focused on hospice and palliative medicine. She's certified by the American Board of Family Medicine in both family medicine, hospice, and palliative medicine. So thank you so much. You're going to be sharing with us how to navigate those comfort care options. I know they can be very, very confusing. When do you need it and why? So I know you'll be going over that today. And I just want to share that we do have an online audience along with an in-person audience. So if you're watching from home, please leave any questions in the chat and we'll address those when Dr. Semmens finishes. So I'm going to go ahead and put your PowerPoint up for you so that you can get started.
Thank you so much. And thank you all for having me today. So we'll be talking a little bit about what is palliative care, who could benefit from palliative care, and then what is the difference between that and hospice. So we'll go on a little journey together. As Maya mentioned, palliative care is a medical specialty designed to help people with serious illness. We really focus on quality of life and the prevention and relief of suffering related to different disease processes. And we really focus on the whole person. We have a team-based approach, and we want to make sure that we're not only taking care of you medically, but socially, psychologically, spiritually, so that we can address all of the needs that go into having a serious and potentially life-limiting process. We are also really helpful as patients navigate their illness with disease-modifying treatment. So for example, if you have a cancer diagnosis and you're pursuing chemotherapy or radiation therapy, we can be concurrent with those treatment plans. We can also be really helpful in preoperative discussions before like a major heart surgery or something that might have a high risk of different complications, and really helping patients navigate what they would not be okay with long-term after potentially life-changing scenarios. In general, when we think about who should we be seeing in the hospital or who should we be seeing in our clinic, we try to target the highest need patients that in general are in the hospital a lot, or maybe in and out of the emergency department a lot. Patients with advanced cancer, especially something like metastatic disease. Patients with advanced heart disease, whether that's heart failure or a large heart attack that's really limiting what they're able to do for themselves. People with advanced lung disease, whether that is COPD, maybe they're on oxygen, maybe they're not getting out of the house as much as they used to. Other lung diseases like pulmonary fibrosis can be very limiting. People with advanced dementia. And unfortunately, in our healthcare system, there tends to be a bit of gap in services, and that caregivers of patients with dementia often have a lot of needs that are just frankly difficult to meet the needs of. But when patients with advanced dementia are starting to walk less, lose some of their independence, particularly with toileting, or have recurrent infections, that's another good time for us to get involved and see how we can help alleviate those things as much as possible. There are many studies designed to look at what are the benefits of palliative care. Okay, maybe it sounds like an extra layer of support, but what is it actually going to give me? It increases patients' comfort. It increases not only the patient's understanding of their medical problem, but the family comprehension of what's going on as well, so that the family and patient can plan together for the future. It increases patient and family satisfaction with medical care. and it decreases things like anxiety, post-traumatic stress disorder, depression, decreases conflict within families themselves or between families and medical team members. And it also decreases hospital length of stay because we ask the tough questions, we get to the point, we find out what people want, and often that can get people out of the hospital to the place that matches their needs best faster. In hospital-based palliative care, there are teams that support patients in many ways. So here at TMC, I have a team of physicians, nurse practitioners, we have a nurse coordinator, we have a social worker, and we work exceedingly closely with our spiritual care team. We've actually kind of adopted one of the chaplains as our own, and she comes to our rounds every day. And what we do is we get to know you, understand how you work as a person, who's important in your life, and then how your disease is affecting those things. We also really enjoy and are experts at symptom management. So things like pain, nausea, shortness of breath. I got to tell you, a lot of times I have patients with dry mouth, and that's one of the most concerning symptoms for them because it's really irritating and really hard to ignore. And so we help with anything and everything, whether that's disease related or treatment of that disease. A lot of times cancer treatments cause their own side effects, and so we help mitigate those as well, so people get through their cancer treatment as easily as possible. We are also really lucky. We work with other support teams in the hospital. We have a behavioral health team that has an activity cart. We work with our pet therapy team and bring dog visits, anything like that. Our team also recognizes that pets are a huge part of people's lives, and we even have little stuffed animals if people can't be around their pets to give them a little bit of softness and comfort in a hospital that maybe otherwise is kind of pokey. When you get a palliative care team member coming to you, these are the types of questions we ask to get to know you better. What's important to you? Now that you're in a different place with your disease process, what are you hoping for? What are you scared of? How would you approach the balance between living longer or being more comfortable? Or what does quality of life actually mean to you? Because what I think of as quality of life may be very different from the person I'm taking care of. I've had people who not at all jokingly say, if I can't get to the golf course, I don't want to do it. And then I'll have a lot of other people who say, as long as I can talk with my family members and laugh and smile, I'm okay. Whether that's home, in a nursing home, or wherever, it's really the people that matter most to me. I often ask if there's any special activities or anniversaries or events that people look forward to. And that makes a really big deal for a lot of people. Sometimes people facing the end of their life really want to see a high school graduation or a wedding or another grandbaby being born. And we need to know that so that we can help them get to those really important milestones. And then what sustains you when you face serious challenges in your life? Sometimes that's spirituality, sometimes that's music, sometimes that's a whole myriad of different things. But if we don't ask about it and know about it, then we can't try to help bring it to you while you're in the hospital. As an example, I was able to meet, and all of these patient names have been changed and their ages have been jumbled. So these are true experiences, but not actually reflecting the person for their privacy. I was able to meet Miss M. She was in her 50s and had stage 4 cancer of her colon. For the last 3 years, she had multiple surgeries and chemotherapy regimens, and she was in the hospital for an infection. She was getting better, and her plan was to get back to her outpatient oncologist for more cancer therapy. So while she was in the hospital, I got to know her, got to know her family a little bit. We helped manage her pain a little bit better, her nausea under better control. We discussed some advanced care planning documents that we'll discuss in a little bit. She wasn't ready for it at that point, so that was okay. And we made sure that everybody was kind of on the same page. She had a really worried sister who was like, I don't think she's telling me the truth. What's actually going on? And so we made sure everybody kind of knew where she was with her disease. In the hospital, my team also sees children. So I know this is TMC for seniors, but we also see children, often in the PICU and the NICU, and we help with outpatient resources and support as well as inpatient coordination of care. Another person I was able to see in the hospital was Mr. J. He was in his 70s and had been diagnosed with Parkinson's about 5 to 8 years prior to his admission for a UTI. He got super confused from his UTI, but then he stayed super confused. And a bunch of different medications were added and subtracted. And I was essentially asked to come talk to the wife about hospice care. But as I understood more about him and his baseline and the fact that he was completely managing their household finances and was like a super smart guy, I realized we needed to look a little bit deeper because maybe hospice wasn't the right thing for him quite yet. We peeled back some of his medications. He kind of came to his senses again, and he was able to go home with his wife without any kind of rehab or anything like that. And I remember her looking at me and saying, "Thank you so much. You saved my husband's life." And so a lot of what we do too is really understanding where people were before the hospital, so that we truly understand what we're seeing in the hospital is just a picture of maybe an illness and where they were before, so we're not making premature decisions. We also have a palliative care clinic. Our outpatient team does a lot of similar things to our inpatient team. We get to know you as a person to make sure that the medical plans that we develop match up with the things that are best for you. We do symptom management, and we also do a lot of care coordination between your primary care doctor or other medical specialists. Our visits have the luxury of being long, 30 to 60-minute visits, so we can really kind of delve into some of the tough stuff that we deal with on a daily basis. And we also have telehealth as an option for patients with limited mobility or scheduling conflicts, so that sometimes we can do it from the comfort of your own home. So back to Miss M, who I met in the hospital. I saw her in clinic several times after that, continued her symptom management with pain, nausea, constipations. She eventually did complete a medical power of attorney, and we started discussions about her end-of-life care wishes. And we did a lot of coordination with her oncology team, so everybody kind of knew where she was and how things were going. Another woman I had the pleasure of taking care of in clinic was Mrs. S. She was in her 60s and was diagnosed with a rare cancer of the muscle of her thigh. Very painful, very debilitating. We worked through a lot of that to help her get through her cancer treatment. One of her big quality of life measures was being a painter. She actually painted for joy and actually had small classes within her adult community on teaching other people how to paint. But with this new diagnosis and her pain, she really wasn't able to do the thing that she loved so much. While she underwent chemotherapy, we helped with her pain management, and her disease improved. We actually got her off of pain medicines, and she was able to start painting again. And this is actually hanging in my office now. This was her thank you gift to me, which was so beautiful. This is a place in Scotland that she had visited many years prior, and it's a place called Rest and Be Thankful. And so I love to look at that every day and think fondly about her, and also wish I was in Scotland. There are home-based palliative care programs as well. These are often sister companies to different hospices in town. Generally, there are monthly visits from a nurse practitioner that review goals of care, make medical plans, support, answer questions. There's, to be super honest, varying levels of training for the people who are in these programs and varying levels of symptom management that they do. And the companies, in my experience over the last 2 years, have kind of come and gone. You should know about them as an option if you really have a need for not seeing someone via telehealth or in a clinic, or if you have friends or family members who might benefit from this. But I also want to empower you all that you are allowed to ask of the training of people providing services with these different companies, so that you know what you're signing up for. In our TMC 1 Beverly outpatient palliative care clinic, it's 3 board certified physicians that run that clinic. Additional community resources that I know you guys all know about because you're so smart that you're at TMC for Seniors is the PEMA Council on Aging, the Arizona End-of-Life Care Partnership, the Arizona Healthcare Directives Registry, which is where after you complete your medical power of attorney and advanced directives, you can actually upload it to that beautiful thing called the cloud, so that any hospital in Arizona can access it if you were to become ill and in need of their services. Every single patient that the palliative care team at TMC gets a consult on, we check the database to see if they have any records. And we have been able to find next of kin to call when a patient presented to the hospital confused and couldn't tell us. And so it's a really fabulous resource. And again, any healthcare institution in Arizona can access it. So it's a really easy way to share your medical records without actually having to, request them from another hospital system. The other resource that you have is your primary care physician. I love primary care physicians. They are amazing, and they can really help if you're not sure if you need palliative care or hospice care or what do you do. They can help guide you as well. So speaking of advanced care planning documents, I'm sure this is all why you're here. One of the most important advanced care planning documents is a medical power of attorney. This is a document where you select, in general, one primary person that would take over your medical decision abilities if you're unable to do so yourself. So this only kicks in if you're too ill or too confused or otherwise unable to speak to the doctors yourself. And I want to reassure you that we try really, really hard, even on patients with breathing tubes in the ICU, to make sure we're asking them first and really keeping them at the driver's seat of their care. But there are times when patients are too sick to know what's going on, and we need to have a person who knows the patient, knows their wishes, and will speak up for what is most important to the patient in these different scenarios. So medical power of attorney is one piece of advanced care planning documents, and the other is a living will. These are written statements expressing wishes for different kind of if-thens in medical care. So if you're really, really sick, would you be okay with things like dialysis or CPR or life support or those types of things? It must be signed by a witness or a notary. You do not need a lawyer to do this. And I'm going to put in a plug for one of my favorite documents. This is the Prepare for Your Care form. What I like about this form is that it's two pieces of this puzzle in one. It's a medical power of attorney form and a living will. What I like about this is that I've had ICU doctors come up to me and say, hey, I was able to see that this patient did this. We were able to actually use it and make a plan. There are some documents that are very narrow, no offense to the Attorney General, but it's very rare for people to be in a persistent vegetative state, and it's a diagnosis that takes months to actually come to. So it doesn't really help in the first couple of weeks in the hospital. Whereas this document walks through, what does quality of life mean to you? What do you want to be able to do? What is the things that you absolutely are non-negotiable for you? And then those ICU doctors or those hospital doctors can look at the current situation you're in and say, this is likely to be able to happen, or this is not likely to be able to happen, and can help you and your family make decisions about how to proceed moving forward. 5 Wishes is another document. 5 Wishes is very detailed. 5 Wishes sometimes is too much for people. So if you're nervous about completing this, or you have a friend who's nervous about doing this, don't do 5 Wishes. I've given 5 Wishes to patients because I've had it. And people then ask me if I'm trying to tell them that they're dying without actually telling them that, because it's so detailed. It's a perfectly valid document. You can skip any parts you don't want, but there's questions about what funeral music you want. And sometimes it just scares people because in general, Americans aren't all that comfortable about talking this kind of stuff, and 5 Wishes goes deep. So this is my favorite document because I've never had someone think that I'm actually trying to secretly tell them that they're dying. This really just kind of gets to what are you okay with or not. Other forms that are really important, I don't know if any of you have heard of the orange form, although I feel like I see some familiar faces from the last time I did this talk. The orange form is the Arizona version of an out-of-hospital do not resuscitate. So oftentimes I have patients that say, you know what, if it's my time to go, I want to go. Or because of this, and this with my medical issues, I don't think that CPR would be beneficial to me anymore. It might just be more harmful than helpful. And so I wouldn't want that to be performed on me. This orange form is well known to emergency medical services as a please protect me from that procedure. And it's something that I often give out to patients in the hospital and the clinic so that it can just be a little bit more clear to people who they might be coming to their house in an emergency scenario. It's also really helpful from traveling from a hospital to a skilled nursing facility and then home. It's kind of a clear, bright orange marker of wishes. The pink form on here is the PULSed or the MOLST, which is the physician order for life-sustaining treatment or the medical order for life-sustaining treatment. This is a national document. So all of our lovely traveling seniors in our community who get to live here in the winter and somewhere else much cooler in the summer, I always actually direct them a little bit more towards the national form, because if you take an orange form to Minnesota, they may not know what to do with it. It's really an Arizona specific form, but the national hot pink MOLST is a do not resuscitate, and there's also things about surgery or dialysis or different medical procedures that you can say you would be or would not be interested in. So these are additional supplementary materials that are kind of one-pagers for some of the stuff that might be in some of these larger advanced care planning packages. Now that leads us to when we really truly are thinking about end-of-life care and what hospice care is. So all hospice is palliative care, but not all palliative care is hospice. I see a lot of people that we have every intention of them being cured or getting better, or we don't think we're in an end-of-life scenario yet. And hospice really is focusing on end of life, usually when patients have a life expectancy of 6 months or less. It is mostly home-based care with intermittent nursing checkups. That home, though, could be home with a family member, a nursing home, an adult care home, whatever home is to a person. There are inpatient facilities for severe acute symptom management. So anything that requires kind of 24/7 nursing care, there are locations where that can be done. But in the US, the majority of hospice care really is done in a home environment. One of the biggest perks of hospice, as I like to say, is they become the new 911. They have 24/7 call where a nurse answers the phone no matter what time of day to answer patient or family concerns or questions. And if it's not something that they can do over the phone, a nurse comes out to the house to help you. So this is really helpful for those patients who really don't want to go back to the hospital anymore, but also don't want to feel like they're stuck with not knowing what's going on. There's always backup with hospice. And again, it's not giving up. It's not any of those things that sometimes are less than helpful medical language tells us. It's really shifting the focus of care instead of diseases and numbers to the person and their comfort. There is also a team approach with hospice care, chaplaincy, social work, volunteers, and another huge benefit that often gives a lot of patients enrolling in hospice peace of mind is the bereavement support for families. After a patient dies on hospice care, there's bereavement support for at least usually a year. I often say hospice people are very, very special people, and they take very good care of their patients. And it is a beautiful service that we underutilize statistically in the United States. It's a 6-month insurance benefit, if you want to think about it that way, and the average length of stay is 2 weeks. Wow. We do it too late. So I often talk about, I say, if it feels premature, it's probably a good time to do it. And it really, it's really a great service. So back to Miss M, my patient from the hospital and the clinic. She came back to the hospital with more chemotherapy-related complications, and her cancer was progressing. It was getting worse despite her chemotherapy. We had a couple family meetings, a couple heart-to-hearts, and eventually she was discharged on home hospice care. She was able, one of her big goals was to do Christmas with her kids again. She was able to have Christmas with her family, and then she died peacefully surrounded by her daughter and her son and her sister in early January. And so though she was angry about not getting the response from chemotherapy that she wanted, she ended up having a really beautiful end-of-life experience. And she was really prepared for that shift in her care because of the conversations that we had started when they felt very premature to her. And I'll end with my experience with Mr. O. He was in his 70s and was diagnosed with metastatic abdominal cancer. He had actually cancer of the appendix. He came into the hospital with a bowel blockage. And many times in cancer of the abdomen, we can't do surgery to fix it. We have to try to let it resolve on its own. Sometimes we put tubes down the nose into the stomach to relieve some of that buildup and hope with steroids and other medications that the blockage will kind of undo itself and people can continue to eat and drink. His was not getting better. Saw him for multiple days and kind of said, we can keep trying to do this. We can also talk about hospice. He eventually discharged to our inpatient hospice house, Pepe's house. Then his bowel blockage resolved, went home, actually signed off of hospice, and went back to his oncologist, got a little bit more chemotherapy. Almost a year later, he was back in the hospital though, and things were much different. He had a bowel blockage again and some fluid around his lungs. Things were much worse with his cancer. I remember walking up to his room and thinking, the wife's not going to be very happy to see me. And she said, "I'm not very happy to see you." I said, "I know." She's like, "But it's only because you ask the questions that need to be asked, and we have to have these hard discussions." He eventually was discharged back on home hospice and died with his family. And she actually called me to let me know and said, "Thank God there are people like you to help people like us. Because even when they don't want to see me, or even when I know that it's hard, we really do try to support people where they are and help kind of prepare them as best as possible for the next phases." And she said they had a beautiful time at home. He was able to play with his grandchildren, and he would not have been able to do that if he had stayed in the hospital. And so they ended up being very happy with his end-of-life care. All right, so that's a little bit about the difference, or the not so differences, between palliative care and hospice, and also a lot and plugs for advanced care planning. Happy to take questions.
So let's take some questions from our online audience first, Dr. Semmens. So one of them is, do only certain people qualify for palliative care?
So no, there are not specific criteria like hospice care usually has. Anybody with a serious illness can qualify for palliative care. So if you're concerned that maybe you would benefit from palliative care, you can absolutely ask for a referral from your primary care doctor or your oncologist, pulmonologist, cardiologist. We also have a relationship with some of the primary care doctors in town where when they know that they have a patient with serious illness, they send them to us. We talk about a lot of scenarios and what ifs for the future, do some planning, and then they don't come back and see us unless they need us. And so I've done a lot of kind of one and done consults where we talk through a bunch, we answer a bunch of questions, and I say, if you need me later, come back. But they may not need anything necessarily right now. I don't do chronic pain management. So I sometimes have people trying to come to palliative care because they're really suffering from chronic back pain, let's say. That's not really considered a life-limiting illness as much as it sometimes feels like it's limiting your life in different ways. And we would be overrun, unfortunately, if we saw all of those patients. So strictly chronic pain is not something that we see in our clinic.
So what would be the most, what do you see the most of, would you say, in the clinic?
The most I see in clinic is cancer related, followed by probably lung disease.
Okay.
And then I've had referrals from neurologists, cardiologists, nephrologists, like kidney disease,
Okay.
If you're like maybe contemplating dialysis or not, that could be a reason for palliative care.
And you see people in the hospital, and then we have the outpatient clinic. So can you just share, where is the clinic, and if somebody wanted to come, what's that? Just maybe go over that process again for us.
So the clinic is at the TMC 1 Beverly Clinic, which is across Grant off of Beverly, kind of where the main entrance, the ED entrance to the hospital is. It's just like a block down on your right-hand side in a cute little old brick building. The best way to get a referral to the palliative care clinic is to ask one of your doctors and say, hey, I want to go to palliative care at TMC 1. That gets everything kind of going through with insurance and all that jazz, and we'll get you on the schedule. Our nurse, Jeanette, triages all of the referrals to make sure that they're appropriate. And when I say appropriate, I also mean like we've had a 101-year-old woman referred to our clinic, and we're like, maybe it'll be difficult looking at some of her notes in the chart to get into clinic. And so we were able to switch her visit from in-person to telehealth, which really helped her and her daughter out because they were really worried that she wouldn't physically be able to come to clinic. And so we want to really make sure that we're meeting the patient's needs in all aspects of their care. And it would not have been a good use of her energy to try to drag herself to our physical clinic when we could definitely do what she needed from us via telehealth as well. And the telehealth option, it's not like computer restricted, like you can do it on your phone. It's just through the MyChart app with our electronic medical record Epic. And it's really easy. I have a lot of people that are like, I don't know how to do technology. I'm like, you literally get a link and you press on it and it opens. And I have never had a patient who was unable to figure out how to do it.
That's great. Is it are they able to see you, or is
Yep.
it just, okay, perfect, okay. And because you're going to want to see them as well, I would assume.
Yes.
Right, okay, good.
And it's a great way too, we will often say, make sure the people who help with your decisions are as involved in your visit as you want. And so I'll have patients bring their spouses or bring their children. And that is the same for the video visits as well. I've had like a cute older woman with her like daughters as her halo in the background. And it's really helpful for us all to be on the same page in that way.
Great. Now, how can you bring up the topic of hospice or palliative care with your doctor? I know, I think sometimes families are afraid to broach those topics. And so how do they bring it up to the doctor or even to their family? I mean, really, that's the other piece of it. So I guess it's twofold.
So that's mostly a very individualized scenario.
What was the question?
How do you bring up hospice or palliative care to your doctor or family? To your doctor, I would just say, hey, I've heard about this thing called hospice care. Would that benefit me? Is that something I need to be thinking about? Because I'll be very honest with you, a lot of doctors are afraid of bringing it up too. And so sometimes if you bring it up, they'll be like, oh, okay, ice broken, let's talk. The other thing is if you have a doctor who's like, well, I don't really know, you can say, well, hey, I heard about this palliative care thing. They'll talk to me about it. Give me a referral. I think the best way to bring it up with family members is I've really been thinking a lot about my medical care and what I'm hopeful for with the future. And I would like to talk to you a little bit more about how things may change. And sometimes the change just looks like we're going to talk about some what ifs. We're going to talk about some documents. Hey, do you want to be my medical power of attorney? And sometimes it can be like, I've been doing these treatments and instead of making me feel better like they used to, they're not actually giving me benefit as much as I used to feel. And so I'm thinking about shifting the focus of my care.
That's great. Now,
Primers.
what about, are there ways to help prepare your family for your decisions other than your advance directives? I mean, I guess it's a lot of conversations, right? But you do want to make sure that they're taking your wishes into consideration if they had to make those choices for you.
So there's a couple of different ways. Sometimes patients watch TV or movies with their loved ones, and there are scenarios in there, and you can be like, oh, hey, what if that ever happened to me? What would you do? And that could be the pop quiz. I've actually, telenovelas tend to be very dramatic, and lots of people have lots of serious mental problems or medical problems in them. And so sometimes that's a way of like, hey, if you're watching TV, has your mom ever said what she would or wouldn't want based upon something that you've seen on TV? So sometimes that can be a good way. There are actually some pretty good documentaries on things like Netflix about choices and wishes and end-of-life care that can be really thought-provoking and conversation starting. There's also a website called the Conversation Project that has kind of one-liner questions on how to start the conversation at the dinner table with your family members. And so it kind of, the Conversation Project. You can actually buy a deck of cards from them and like go through it. It's a funny game, but like helpful. But they have some like easily accessible free stuff on the internet as well in terms of how to kind of broach this with family members.
It's not always easy. I know that we oftentimes hear about people holding it over Thanksgiving dinner as well. So I've heard that many times where that's going to be the topic is going to be over the Thanksgiving dinner. So.
And there are lots of resources, I know that a death doula was brought up earlier. There are people who have different training in how to have these conversations and walk people through like the process of preparing for their deaths. There's death dinners where like literally the conversation is death and like, what do you want? What don't you want? But I think oftentimes you can also just make up a scenario of like, oh, hey, this woman from my book club had this scenario. Can we talk about that more? Or, hey, I went to this talk at TMC for seniors and this doctor kept going on and on about how every adult should have a plan. We've never talked about it. Should we start? And I think the truth of the matter is that it's not usually a one and done scenario. So it's not like you're going to have this big talk over dinner and be completely done. But a lot of things can kind of start percolating and marinating and simmering, and then you can circle back to it. I think a lot of people have concerns about, oh, it's going to be uncomfortable, so I just won't do it. But I, on the other side of people in the hospital, will be like, have you ever talked about this? And people will be like, no, and we should have. This is so much worse because we never even tried. So I guess I should have brought little like courage coins to give to you all. Like, here, take some of my courage and you can do it, right? Like, oh, there's something tangible of like, we got to get this done. But I think even just being here and having a conversation in your own mind can help frame those conversations. And instead of being completely new to you, you've thought about it a little bit and can guide that conversation further.
And I think you gave some great examples of ways that people can approach it, so I appreciate that. A question just came in asking, who qualifies for being a medical power of attorney?
Great question. 18 years old. I'm going to actually go through this because there's like the technical qualifications and then the like also shoulds. And so this is another reason why I really like part 1 of this document. So they have to be an adult. I often throw my poor sweet husband under the bus and say that my husband is not my personal medical power of attorney, because if I were sick enough to need a medical power of attorney, he would be a wreck. He would be emotional. He would be panicking because I'm the medical person in the family and he's not medical. And he'd be like, too much pressure, so paralyzed by not wanting to make the wrong decision. So my gift to him is that he doesn't get that choice. And it's my girlfriend, who's a physician. I'm lucky in that I'm a physician, so I know a lot of doctors, who will involve him, but knows me, what I want, what's important to me, and will advocate for what I would say, even if she would really rather something else. Because we're all a little selfish when it comes to the people we love, and we want them with us. And that's normal. That's human. That's okay. But I made sure to pick someone who would be like, nope, Shana told me, blah, blah, blah. We can't do this anymore. And so it's someone who you trust to follow your wishes, not their wishes. It doesn't have to be the obvious person, like your spouse or your sister or whomever, but it's the person who actually knows you best. And I think that's another way to bring it up with your family of, the gift I'm giving you is not wondering. I'm going to tell you. So that it's not their decision, they're just voicing your decisions, and then they don't have to worry about whether or not it was the right one.
That's great. Somebody just asked about where do you get that form? So we, of course, have the 5 wishes here, but you can also get the Prepare for Your Care form online. And I think it was I actually just pulled it up myself. I think it was Prepare for Your Care. So you can just type that in and you put in your state and you can actually download or complete the form there. Can you talk about the mental health care power of attorney and why that is different here in Arizona maybe than other states too, because not everybody has that?
So Arizona has separated out medical decisions from mental health decisions, which, if you want my personal opinion, is silly because it's both the same thing. But like the Attorney General form, and there's actually a couple one-pager short forms that are available. There is not only a place for your primary and secondary medical power of attorney, but there's maybe a little checkbox that says the above person also has my mental health power of attorney. This is really important for any sort of psychiatric things that may need to happen. And a lot of times I'll have patients be like, well, I'm not depressed. I don't have like schizophrenia. I don't need that. But often because of the blending of things like dementia and mental health and behaviors and hallucinations that sometimes go with some of these medical diagnoses, I always encourage my patients that if they're doing that to, yes, check the mental health power of attorney as well, because it helps just make sure that someone on your side, like who knows what you want, has full access to your medical care in all the different ways that Arizona separates it out. So if there is not a section on some of these forms about a mental health, you can always addend that, and there's always a section that says other wishes, and you can say, would want this person to be my mental health power of attorney as well.
Great, that's great information to have. My last question is about the orange form. So can you share a little more about how the orange form works? And when does that get used? Like, when is it really used?
So the orange form is just this. It says your name, some things like your date of birth and like what color your hair is. This little circle is for you to put a recent photo so that if someone comes in an emergency scenario, I always try to be really dramatic, like Grey's Anatomy. EMS bursts into your home and no one else is there and there's an orange form and you're on the floor. You want to make sure that the right form is for the right person. Okay, like that's why there's a picture place. You laugh, but the stories I've heard. And so then it literally just says, please do not do CPR or put me on a ventilator, a breathing machine. It is very recognizable for emergency medical personnel in Arizona that if that's what's here, then they are going to respect that as much as possible. It is not like a medical order like we can do in the hospital. So there are always concerns that if there are other people in the home saying, oh no, she didn't actually want that, like what's going to happen? But we use this very seriously in the hospital, that if a patient has done that, then that's their wishes. And so that's number one, be above whatever the family may or may not be saying. And so we do everything in our power to honor whatever wishes people write down. And sometimes that's a lot of hand-holding from my team or emergency team or the ICU team of kind of guiding family members into how much thought goes into doing this. The other piece that's needed is a physician's or an advanced practice provider's signature. So your physician, nurse practitioner, physician assistant can sign it, and then it has to be witnessed as well. All of these forms have an area for a notary. You don't have to have them notarized, but they have to be witnessed. So don't sign any of these until you're in front of a witness.
And how is that different from the PULSed form?
The PULSed is national. The orange form is Arizona.
Okay, so very similar.
They're very similar. The PULSed is an order, so it technically has a little bit more legal weight, I guess. And the other thing is that there are other areas to check on the PULSed form for things like dialysis or surgeries or artificial hydration and nutrition. So this is really a CPR yes or no, whereas the PULSed has a CPR yes or no plus a couple other things.
Great. Okay. I want to thank you so much for being here. I'm going to turn it over to your online audience so that they can ask any questions that they have. I'm also going to put up right now about hospice. So if anybody is interested in learning more about hospice, I want you to be able to call. The phone number is 520-324-2438, or you can call, you can also look it up at hospiceinfo@tmcaz.com. So thank you so much, Dr. Semmens. This was great information, and we look forward to having you again.
Thank you.
So thanks again for being here. We are going to be having an in-person class tomorrow, and that is the Inside Story, and that's going to feature an end-of-life doula. So if you're interested in attending that class, again, this one is just in person. It's tomorrow, Wednesday, April 24th at 10 a.m. Please give us a call in the office. The phone number is 520-324-1960. And if you're interested in having your directives, your medical advance directives, if you need any kind of help with that, we do have somebody that comes, a volunteer that works out of TMC that will meet with you one-on-one. So if you would like an appointment for that, please give us a call. Again, the phone number is 520-324-1960. Have a great day.